scale, which have two main concepts. One is the characterization of pain intensity, as well the disability. I'm having issues advancing my slides. I apologize. And that other variety of instruments in the characterization of the psychosocial domain of the patients, you have the grade of chronic pain scale, pain drowning, jaw function limitation scale to see how they function with their masticatory system, the PHQ-4 that I mentioned. I have two questions for depression and anxiety, PHQ-9, which is for depression, JD7 for anxiety, the patient health questionnaire, and the oral behavior checklist, which have an implication in diagnosis. We use it as a proxy as well, other clinical information to get to the diagnosis of nocturnal and diurnal bruxism. But as I mentioned before, Dr. Orban will go in detail in each of them. And the case presentations for you, or the case, how we will be presenting the cases for you for your final exam, will incorporate these instruments already scored for you to interpret what to do with the information. But for today, let's concentrate. Again, problems advancing, but I will use this one here. Let's concentrate in the Axis 1 clinical diagnosis, specifically the TMD pain conditions. Actually, before I move there, I want you to kind of remember this diagram or this figure that will be incorporated in many slides, because this explains why a particular individual or a patient have to be assessed or characterized both in the Axis 1 physical domain and in the Axis 2 psychosocial characterization. Why? Because you may have individuals with very little physical domain or diagnosis and a lot of psychosocial, or any possible combination, a lot of both, little of both, little of one, and a lot of the other. So it is important because at the end of the day, characterizing or identifying which other factors and which other comorbidities are present are going to allow you to tailor better a treatment plan for that patient. Ignoring Axis 2 and thinking that a mouth guard may fit or may fix actually any TMD condition is a very poor way of thinking about it, because then you are doing a very narrow mind and focusing just on the teeth. And I'm sure Dr. Crow will develop more about mouth guard, but I think all of you at this point of your educational experience at least have here or provide or seen mouth guard being delivered for patients with bruxism problem and maybe some TMD diagnosis. No questions so far. Okay. So the most common painful TMD conditions, and that's why this is bigger here, is because that's what we are going to be talking about. So you can do as little as using the painful TMD screeners, which is a screener, which I know is introduced to you by Dr. Anders during your rotations. Although I know that this year the rotations have been a little bit modified. So if you haven't been introduced to, I apologize, but it happens to be that Dr. Anders utilizes the instrument when he starts ODS rotations, when you do assessment of your patients. And the beauty of this instrument is the fact that the sensitivity and specificity values, there it is, are extremely high. So the likelihood of somebody having a painful TMD condition only works for painful TMD conditions. And we will develop in a minute what are those by answering a 1 minute form and is extremely high. It is above, I'm trying to see what is the lowest number, it's above 95%, which is extremely good. So imagine for a minute you graduate next year and you don't want to take care of these patients because you don't remember, you don't like it, it's too complicated. That's not really what you want to do. At least you would like to use the screening instrument to have in the record that you assess that. Now, if you are like us, and I mean like Dr. Katouf, Dr. Crow, and myself, which we dedicate our academic life to orofacial pain conditions, you may go more in detail and actually use this kind of algorithm that allows you to get to the diagnosis of myalgia, myofascial pain with referral, arthralgia, and headache attributed to TMD. And this format here is telling you that you once again need some history components, and the SQ comes from a symptom questionnaire, and then the E1 through EX means that those are elements of the examination protocol. The other one, or the other thing I want you to be aware is that I mentioned here myalgia, myofascial pain with referral, arthralgia, and headache attributed to TMD. So myalgia, myofascial pain with referral, arthralgia, and headache attributed to TMD. And those are the four diagnoses that have estimates of sensitivity and specificity. So I have, and I will show you the values, but those are the ones that I have levels of certainty when I provide this diagnosis. Local myalgia and myofascial pain alone, they were not validated in this validation study. And these diagrams, as well as all the instruments, including the symptom questionnaire and the examination form, if you go to Inform in the web, you can download all the information. And again, it's as well free for all those who would like to download it. So let's talk about myalgia first. Myalgia, as the definition, is pain of muscle origin that is modified by function and parafunction. And that pain of muscle origin, obviously, we're talking about muscles of the masticatory system or the masticatory muscle. So by history, I'm sorry, you have to have the question, the omnibus question that we use is pain in the jaw, temple, in the ear, in front of the ear, and that pain have to be modified by function or parafunction. In terms of clinical exam, we have to confirm the localization of the pain in the temporalis and masseter muscles, and we have to replicate that pain of chief complaint during provocation tests, which include either range of motion when we are measuring the range of motion, specifically maximum unassisted and unassisted opening, and palpation of the temporalis and masseter muscle. So I will continue talking, but here is the first question for the class. Why will the definition be only limited to temporalis and masseter? And I will pick a random name when I get there to get my answer. So from the history component, I told you first, there is a history element that based in your bubble sheet, you are getting from the SQ. So here we go to the SQ, which is the symptom questionnaire, and the numbers match. It says SQ3 and SQ4. Well, SQ3, I told you, is that omnibus question that asks if in the 30 days, which of the following better describe any pain in your jaw, temple, in the ear, or in front of the ear in either side, right? And obviously, no pain means the patient didn't have pain. And if they answer to any of these two, that the pain comes and goes or the pain is always present, that is technically a yes. So no for no pain and yes for any of these two questions. The second question from history was that pain has to be modified by jaw function and parafunction. And that again is your question from the symptom questionnaire. in which you have in the last 30 days did of the following activities modify your pain. And the modification is bidirectional. It says either makes it better or worse in your jaw temple, in the ear, or in front of your ear. And as you can see, chewing hard food is a functional question. Opening your mouth or moving your jaw forward to either side is a functional question. Jaw habits such as holding your teeth together, clenching, grinding, or chewing gum is a parafunctional question. And other jaw activities such as talking, kissing, or yawning is a functional question. So if the patient answered positive to any of this, means that they're, and obviously, and if they answer they have pain, that means that their pain is modified by either function or parafunction.
Dr. Gonzalez.
Yes. Who is talking?
Monica.
Monica, how are you doing today?
And how are you?
I'm doing well. Can you open your video so I can see your face?
Sure.
Thank you, Monica. There you are. Oh, much better. Thank you. So I'm looking sideways because that's where I have the picture. So I'm paying attention. Go ahead, Monica. You have a question.
Yeah. Is the symptom questionnaire is the same thing as the PHQ?
No, Monica. The symptom questionnaire is the instrument that have standardized questions to arrive to the access one. The PHQ is called the physical history. Let me go back there for a second. Okay, so the symptom questionnaire is part that is going to allow you to get to the physical diagnosis. The PHQ, patient history questionnaire, were developed in medicine in order, it's a series of them, as you can see, you repeat PHQ4, PHQ9, PHQ15, actually there's a PHQ8, and they were done as a group of instruments in order to assess the psychosocial domains of the patient, specifically distress. So they are focused on anxiety, somatization, and depression.
Okay, so when a patient comes in, you give them two questionnaires, basically, the symptom questionnaire and the PHQ questionnaire.
Well, you will give the patient many instruments. You give them the symptom questionnaire, the PHQ9, the PHQ15, the J87, the grade of chronic pain. We give them as well the sleep questionnaire, catastrophizing questionnaire, and the Tampa kinesophobia questionnaire. So, so you have an idea how it functions in the clinic. If it's a postgrad patient, we do our best to, in the moment of registration, to send a package to them home so they can complete all this. So they come in and we can review them and score them. And before they even come, we have a telehealth visit in which we address the medical history, medication intake, and the history of chief complaint. So, it takes a good half an hour for them to answer all these questionnaires. But you have to be aware of, because as I mentioned to you, not only for examination purposes, but parentheses, you will have these instruments scored and given to you for your final exam, your final cases. In the pre-doc, with the pre-doc students, just to clarify that as well, when the patient comes to our clinic, there should be a minimum of their the symptom questionnaire that you ask, the PHQ4, that is minimum for depression and anxiety, grade of chronic pain, and the obesity. So it's a less number of instruments, but it's still some of them. Did I answer your question?
Yes.
I tend to talk a lot instead of answer the question directly, but let me know and I can summarize. Yeah, okay. So thank you, Monica. I appreciate that you are with me. Okay, so as Monica clarified, these symptom questionnaire questions are answered in order to fulfill that algorithm that goes for the access one. In addition to that, here you have that you must have some examination components to get to this diagnosis of myalgia. And those examination components, first is the confirmation of the pain by telling them these are the areas of interest, show me where your pain is, and we will confirm. And we have to confirm that the masticatory muscles are involved, either the masseter or the temporalis. So, and notice that in your clinical form here, you have question 1A, in which you identify if in the right or the left, which anatomical structures have pain, okay? So we confirm the localization of the pain in the masseter and temporalis, followed by trying to replicate the pain during range of motion or palpation. And the range of motion specifically that we use for myalgia is going to be maximum unassisted opening, in which you remember from last week is the amount of opening they can do with, even if it's painful, or by maximum assisted opening, in which now we ask the patient for permission, and with our fingers we try to help to open their mouth a little bit wider. And how you record that in your examination form for myalgia is going to be only during the what I call vertical range of motion. And if they, after you include your numbers here, your raw numbers of what you measure with your ruler, after each movement, you are going to ask them, did you experience pain? Show me where. And then, you will illustrate or mark where here. And you have temporalis, masseter, and I'm concentrated here in myalgia, so other masticatory muscles, if that pain was familiar in the right and in the left side. In addition to confirm the pain during the maximum unassisted or assisted opening, you will have to see if you, in addition, if you replicate the pain during palpation. So don't forget, you have to calibrate your finger, and you are going to be doing palpation of the temporalis and masseter in the manner that, or following the protocol Dr. Katouf showed to you last week. And again, you will record that in your clinical form, in which you record for the temporalis, posterior, middle, and anterior band, and for your masseter at the origin, body, and insertion. If you have pain, if the pain is familiar, I will stop only right there. If you have pain and the pain is familiar, even though when you do your exam, you will do as well if it's familiar headache, if it's the temporalis, and for all of them if it have a referral pattern. In addition to that, you will do those supplemental muscle palpations, in which you have the posterior mandibular region, the submandibular region, the lateral thoracoid area, intraoral, and the temporalis tendon, and you ask the same questions. And this will allow you to determine if your patient has myalgia. So a few minutes ago, I asked the question, why do you think the criteria of myalgia by the DCTMD only limits all these concepts to the temporalis and masseter replication, confirmation of the pain in those areas, temporal and masseter, and confirmation of the pain in the temporal and the masseter. So Monica already talked to us today. Here I'm looking at the names, and I have, let's pick, I don't know, randomly a name that I can mention. Daniel Connors. Daniel, are you with us?
Yeah.
Hi, Daniel. You can turn on your video if you're so kind. And tell me, why do you think we limit that to masseter and temporalis?
I honestly do not know.
That's okay. I take that as an answer. What about Alexa Page? Alexa.
Hi, how are you?
Hi, Alexa. How are you doing? Would you like to open your video, please, so we can have a visual? Oh, and yeah,
Hi.
nice to see you.
Good to see you too.
So why do you think the DC limits this to the temporalis and masseter? Should I have, if I have a patient that has pain in the lateral pterygoid region, should I tell my patient, you know what, go home. My DCTMD says temporalis and masseter, so come back when you have pain in the masseter and the temporalis.
No, definitely wouldn't want to say that.
Very good. I'm with you, Alexa. Excellent. So why do you think they specifically mention those two groups of muscles and no others?
Because they both insert in the same location on the coronoid process.
The temporalis tendon flips there, but they are not exactly in the same location, and that's not the reason anyway. Any other reason that may come to your mind?
You can
It's okay.
palpate them.
You're right. They are. You know that answer came a lot. Have come a lot in the past. It's very easy to palpate those, and we can be more reliable at palpating the temporalis and the masses. The other reason, Alexa, and something that I want you and everybody else to be aware is that when we did the validation study, actually the prevalence, the number of individuals that will have a myalgia diagnosis without having these two group of muscles involved was extremely low. It was less than 2% or 2%. So meaning that most of your patients that are going to come with muscle pain or complain of muscle pain, the likelihood of them involving the masseter and the temporalis is going to be extremely high, 98% of them, right? Nevertheless, I like your answer when you said you will not send somebody home if other muscular region will be on pain, and if you replicate it, that's what we show palpation of the supplemental muscles, right, or the supplemental areas, and you will say it does not fulfill the CTMD diagnosis, but I'm going to treat my patient as well because I don't want to wait until those other muscles are involved. Thank you so much, Alexa. I love it. Thank you so much.
Yeah.
Thank you for participating. So myalgia is probably the most common one. Data from our TMD clinic show that myalgia was present among those patients that received a DCTMD diagnosis over 80% of the time. And notice here, I know it's very small, but the sensitivity and specificity concepts that you should be familiar with, especially in this era of COVID, we talk a lot about the sensitivity of the different tests, right? And the specificity. So just to remind you, sensitivity, the ability to identify your true positive, specificity, your ability to identify your true negative. I think that's a good summary way to put it. So that means that I'm 90% certain when I allocate this diagnosis that in fact the individual has myalgia, and I'm 90% certain when I don't allocate this diagnosis that, and I said the individual doesn't have it, that is a real true negative. That's very cool. That's very, very high. Any questions so far about myalgia? So here is Suri. Suri is now a physician. She was an honor student at UB and many years ago did research with us in the TMD. And, she happened to have, she gave me permission to use her picture. And she happened to have pain in the masseter region. And that's why we use her picture here. The next group, I don't see any questions. The next group is myofascial pain with referral, okay? So this is now misspelled, that's how it's written, okay? And what is the difference between myalgia and myofascial pain with referral? There is one major difference that I'm trying to illustrate here with this picture, and it's the fact that myofascial pain with referral, the pain that you replicate in the muscle during palpation goes beyond the boundary of the muscle that you are palpating. So it still is a pain of muscle origin that is, modified by function and parafunction. But the main difference is that the pain, when you replicate the pain upon palpation, that pain goes beyond the boundary of the muscle that you are palpating. The same two questions from the symptom questionnaire. And then we have the confirmation of the pain in the temporalis and masseter, and we talk about that have to be familiar, and that is upon the palpation goes beyond the masseter muscle. So here, when you are doing your palpation, and this is again in the clinical examination form that was explained to you last week, the examination, you ask if it's a referral pattern. So pretty much goes like this, right? Imagine I'm my own patient, so I'm palpating in the muscle and I'm in the masseter body. So we apply the 1 kilo pressure for 5 seconds, 1,001, 5 seconds, and then I will ask pain, and I will answer as well if I was the patient. Yes. Is that pain familiar? Yes. Is that pain only under my finger, or do you experience that pain someplace else? And now the patient will tell you, I feel it someplace else. Show me. Well, I feel it all around here. So now the examiner comes and confirms in this area here, well, it's still within the masseter. Versus, no, I feel it someplace else. Where? I feel it right on my front tooth. So definitely front tooth is out of the boundary of the masseter. Or the patient may feel, I feel it like inside my ear, is out of the boundary of the masseter. Oh my gosh, I feel it right on my eye, is out of the boundary of the masseter. I feel it right on my temple, is out of the boundary of the masseter. Asking the patient, is this refer, yes or no, is not a good practice, because now you are allowing the patient to determine what is referred. You have to confirm the referral pattern by checking the area where they feel the pain, they mean the patient, and you as the provider have to determine if it's within the boundary of the muscle, yes or no. Any question about this? No. Okay. And actually, this becomes very important, and I remember Dr. Katouf mentioned that, because sometimes even becomes a differential diagnosis, in the sense that you may have individuals complain of odontogenic pain that actually is referred pain from the muscle. And so it's important, right? If I'm palpating in the masseter and I say, oh my gosh, I just got my tooth pain. That's the tooth pain, and I'm talking about it. You kind of confirm that is referral in origin, right? And there've been a lot of case report presented in the literature in which individuals receive odontogenic treatment when in fact was myofascial pain with referral, or they may be receiving, let's call it TMD treatment for now, when in fact is odontogenic pain. So look for that. The next category.
Dr. Gonzalez, can I stop you for a minute?
Yes, thank you, Dr. Cross. Welcome.
Thank you. Could you just go over the sensitivity and specificity of the myofascial pain with referral? Because I think that the difference there is important as well. Thank you.
Thank you so much. And I just want to add to that, to the class, that, it's not too much fun to teach talking to the computer and talking to yourself. But this year, having Dr. Crow and Dr. Katouf and having this very interactive, I found that this very fascinating, because if we forget something, like I just omit the sensitivity and specificity, Dr. Crow can help me and we can help each other. So, and any of you are welcome to ask questions as well. You are correct, Dr. Crow. I forget to mention sensitivity and specificity, and the sensitivity is 86%. It goes down a little bit from 90 to 86, so 4 points. And the specificity from the myalgia was 99, now goes down to 98. So now that Dr. Crow reminded me that, I have a question for the class. And why do you think the sensitivity will go down? Why will the sensitivity, why will the ability of identifying the true positive will come down? And again, I come here to my random list of names, and I have Savannah Tomaka. Savannah, are you with us? Maybe Savannah is not with us. Harlem Kaur Sohi,
Yes,
are you wanna let us see you so we can say hi?
Hi, Dr. Gonzalez. How are you?
Hi, how you doing? Good morning. Happy Tuesday.
Yeah,
So
same to you.
Thank you. So the question was, why will the sensitivity drop down from myalgia to myofascial pain?
I'm not sure about that.
Oh, give me a little bit. Think about it. Every question, every answer, we take it.
Can you repeat once more, please?
So why I'm not as certain when I provide the diagnosis of myofascial pain, I'm not as certain as when I provide the diagnosis of myalgia. I am only 86% certain versus the myalgia I was 90% certain.
Maybe
Like the grades, right? You prefer to have a 90 than an 86. So why?
maybe like kind of a referred pain.
Well, by definition, it's a referral pattern. You go beyond the muscle. So, Harlem, you can call a friend who you want to call to help you to answer.
I can call Sean.
Okay, Sean, are you in? Sean didn't want to. Oh, Sean is there. Wow. Doesn't read as Sean in my list, but I will assume you call him Sean. So Sean, we can, okay. So why will the sensitivity go down? Sean, you are muted.
Yeah, I said I think because the chances of false positive will be increased in myofascial pain.
Well, you are absolutely correct. If the sensitivity goes down and you cannot identify your true positive, it's because you will have a higher rate of false negative, right? But why? So you want to call a friend? I just will let you call one more friend and I give the answer.
Dr. Gonzalez, is it something like it's hard to maybe replicate or something?
Yes. So absolutely. So the phenomenon per se is much harder to identify. That you got it. In addition to the fact that the prevalence of the phenomenon may be affecting the sensitivity. So if I have a group of 100, it's harder to identify or replicate the findings, and the prevalence, the number of individuals with the condition may be lower, which affects sensitivity and specificity calculations. You see, you got it. Both of you, excellent. Dr. Crow, you have a comment? Any other comment about the myofascial pain with referral?
No, that was exactly what I was hoping to hear. So thank you.
Yeah, you did it, Harlan and Sean. Very good. The next group that we are going to address is the arthralgia group. So arthralgia, by definition, is pain of joint origin, which is affected again by function or parafunction, and that you will be able to replicate during your clinical exam. So by history, you have the questions from the SQ, and during your examination, you will be able to confirm that either during range of motion, and in this case will be any range of motion, or during palpation of the joint, which we do in two manners. We do the lateral pole and around the pole. And from your symptom questionnaire, again, we're still in the same questions. That's what the patient is telling us, that they have pain and that it is modified by either function or parafunction. We, after explain the areas of interest, can confirm. So actually, it's only this picture. I don't want to escape to eliminate this one, but I will do that. And then when we confirm the area, it will have to involve the DMJ, either right or left or both. And then do the maximum unassisted, maximum assisted, right, left, lateral, or protrusive movements. The patients are going, they could say that they have pain in the TMJ and any of the movements, which is familiar. That will allow you to confirm that pain, or while you do palpation of the joint, either in the lateral pole, which is done with half kilo, or around the pole, which is a dynamic, I don't know what happened, or around the pole for 5 seconds, which is a dynamic palpation. Then when you do this, you are going to be confirming, meaning that the patient is going to tell you, yes, I do have pain. Yes, that pain is familiar. And that part, I didn't include the clinical exam where the block says lateral pole, around the pole, pain is familiar. Something important to remember as well is that Dr. Katouf mentioned that we still ask the patient if the pain on the joint, which is familiar, if it's referral or not, if it's only under my finger or someplace else. But remember, we don't have a diagnosis such as arthralgia with referral. So in that clinical exam that she taught you last week are several elements, being the referral during the joint palpation, one of them that don't have any clinical input for the diagnosis. And once more here, how is the lateral joint palpation, and then the around the pole palpation. And that was what my patient here, Carla, again, using her picture with her permission, was trying to identify about the location of the pain. Any questions about arthralgia? So arthralgia is very parallel to myalgia. Eye block. The next group is probably one of my favorites. I hope it's going to be one of your favorite too. Before Dr. Crow asks me, I want to tell you the sensitivity and specificity. There is a summary slide coming forward, but the sensitivity and specificity of arthralgia is 89% for sensitivity and 98% on specificity. So I must add to that comment of sensitivity and specificity. In the past, before the validation study, the palpation used to be only in the lateral